As technology in healthcare improve, more patients are surviving surgery, but we don't know if or how their quality of life changes. Following surgery, the NHS traditionally measures outcomes such as 30-day mortality and post-operative length of stay. These are important to healthcare professionals and to hospitals, but they don't cover the full range of issues which are important to patients, such as whether they get back to their usual level of physical activity and general well-being. This is where patient-reported outcome measures, or PROMs, come in. PROMs are questionnaires that asks patients to self-report about their own health. They can be used to assess the impact that interventions and treatments may have on patients' quality of life. For example, compared to 1 year ago, how would you rate your health in general now? There are many PROMs available, which all measure different things, such as well-being or patient satisfaction, and for different purposes. PROMs can be applicable to all clinical areas or conditions specific to things like inflammatory bowel disease. One of the PROMs that PQIP uses is called EQ5D5L, which is a generic measure of health-related quality of life across 5 dimensions. Your mobility, your capability for self-care, your ability to undertake usual activities, the amount of pain or discomfort you are in, the amount of anxiety or depression you are feeling. For each dimension, patients grade their response to one of 5 levels: none, slight, moderate, severe, extreme. The responses can be used to create a health index, a single score that can be used to determine the value of healthcare. We can use PQIP data to provide better information to patients and clinicians about the likely impact of surgery. This means that patients, along with their families and friends, will be better prepared for any predictable challenges following potentially life-changing surgery. It's really important that PQIP data is representative. This means getting as many hospitals involved as possible and getting good response rates from patients. Join our team of collaborators at www.pqip.org.uk. Thank you for listening.
Hi everyone, welcome to the last session of the day. My name's Anne-Marie Boujard. I'm the Perioperative Medicine Fellow at the Royal College of Anaesthetists.
Good afternoon, my name is Matthew Bedford. I'm a colorectal trainee, just finished my training up in the West Midlands, and I'm one of the PQIP surgical trainee representatives.
So while everyone's taking their seats, I don't need to give much introduction to the next speaker. Mike Swart's already been on the stage this morning, so he's going to talk to us about how he supports shared decision-making in his long practice of doing so. Thanks, Mike.
Very long, very, very long. Good afternoon, and thank you for staying. So, I was asked the question, how do I support shared decision-making? And that's the answer. The first is giving lectures, which I've got to say is the worst way to teach anything about shared decision-making. Then some workshops. We've adopted the MAGIC workshops, and we've done a number at the college and locally in the southwest, and we need to do more. Then I think videos. We're going to plug the UCL MOOC. There is a video of myself doing a consultation, and I think we need more videos, both to teach shared decision-making, but also to assess our own shared decision-making. Clinics and stories. I think that's a good way of teaching it. And finally, you learn shared decision-making from patients. So what am I now going to briefly talk about? 3 things. What is shared decision-making? How did I get into this? And what should we do next? So the background, the first, or to my knowledge, the first use of the word shared decision-making goes back to 1982, when there was a document developed by a group of lawyers and ethicists in the United States to look at how do we improve informed consent for either patients having procedures, investigations, or for research. And we haven't really moved, I think, a great deal since then. I think we've got a lot to do. So start with what is shared decision-making? And I'll try and tell this with a story. The first thing I need to do is to acknowledge that where I work, We've been doing something like this for over 15 years, and the people I'm most proud of is, of course, the patients, but the surgeons I've worked with over the years and how we've developed this together. So last week I was doing a day surgery list, and on it we had an elderly lady for a bilateral laparoscopic hernia repair. And her husband dropped her off. It became apparent that she was a little bit confused, that actually consent wasn't going to be that straightforward. And the surgeon rang the husband, had a discussion with him, and did the whatever special form it was for consent with somebody who lacks capacity. The decision was made to proceed with surgery on the basis of she'd had a number of visits to the GP with pain, and it was thought to be in her best interest to proceed with surgery. So I'm going to ask you to raise your hands if you think that is a shared decision-making decision. Anyone? Great, great. Anyone else? Few more. So how many of you think it isn't a shared decision-making consultation? God, I can walk off the stage now. You're in the majority. Now, the next thing this precipitated was I tried to get the surgeon to get this gently. So I said at the beginning before he'd even seen the patient, I said, we could have a problem here. This lady doesn't know why she's here. And she'd shared this with the nurses. Been dropped off, she didn't know why she was here, she didn't know she was going to have an operation, she didn't know what drugs she'd taken or not taken. It also became apparent that the day before, she'd had an injection in her eye for macular degeneration, and this had really upset her and made her more confused. So I didn't feel, and the nurses didn't feel, and the trainee anaesthetists didn't feel that this was quite right. And actually the pain, she didn't have any pain. So I said to the surgeon, very politely, I think that's a surgical decision. I don't think that's a decision based on the patient's perspective. And he went ballistic. It really upset him. And he's someone I've worked with for 20-odd years, and we had to leave the room and go and have a chat in private about this. And I was really taken aback. Now, I don't think he's a bad man. I think he's a good man. I think he was doing what he thought was in the patient's best interest. But that was still a decision based on a surgical perspective. It was not based on the patient's perspective because nobody had tried to find out what her perspective was. So, end result was we did manage to calm things down. We had a very enjoyable list together, and I'm seeing the lady next week with the husband to go through, well, what might happen after the next procedure, and could her dementia or memory loss get worse? Now, that's how you teach shared decision-making. And I will use this to go back to the surgeon at the right time to explain why we had a difference of interpretation of language. Because I think that's where the problem is. It's interpretation of language. So, 3 styles of consultation up there, or types. A checklist that you do before you do an operation or a procedure to check it's safe both for you and the patient. Say on the day of surgery, and well, as we did in the day surgery clinic. Second is your medical diagnostic model, where you do history examination to close down to a diagnosis. Shared decision-making is where you find out what patients want. Also came up with this recently, or this as an idea. Those 3 styles may be right in different times. The first is the paternalistic, the doctor decides. I'm going to probably lose everyone here. I do believe in paternalistic medicine, right? Only when you've done the shared decision-making first. So you may move to a paternalistic style, but you have to do the shared decision-making one. What I don't think we should be doing is going, right, patients should decide on their own without any of our support, apart from to give them information. So that I think this information overload without working with a patient, I don't think that's right. The structure. Say you're going to have an operation. So you identify options of operational alternatives. You go through chance of harm or benefit from all the options, including doing nothing. Acknowledge uncertainty when it exists. Ignoring it doesn't make it go away. Identify the person's personal preference, and I think that's really the key to this, and that's the one where you need to develop your consultation skills. Then you make a plan, you communicate the plan. I'll try and demonstrate this in a diagram. So you've got a doctor and you've got a patient, and you've got an area where they're both involved in the consultation and they understand what each other are talking about. But below it is some unresolved or unvoiced knowledge, beliefs, or values, things that the patient doesn't know the doctor is thinking, and the doctor doesn't know what the patient is thinking. And the shared decision-making consultation is meant to move you to this common ground where you're sharing something, and that helps the patient make decisions. Now, it's clear that you cannot share everything with a patient. It's not possible for you to share all your knowledge and experience. It's also not possible for a patient to share with you all their knowledge or experience. But what you've got to get is that common ground. I'm going to do this in a slightly different way now. So we've got Joe and Sam. And Joe lives in London, Sam lives in Cambridge. And they're internet dating, something like that. I gather that occurs. That's Joe, just come out of a relationship, didn't do very well, and basically he's a bit tight. He doesn't spend much money on his girlfriend. So he goes, I've really got to make a good impression here. So they agree to go on a date. And then to really show off, Joe takes Sam to Hawksmoor, looks up where's the best steak restaurant in London, 7 Dials, Hawksmoor. The only problem is this. Now, this is an example of if you don't ask, you will not know. So how did we get into this? 21 years ago, up on the top corner is a picture of Paul Older, who published a couple articles on cardiopulmonary exercise testing. And myself and John Carlisle, a patient who did give us consent to this photo and a cardiopulmonary exercise testing machine, we started doing this, and we didn't know what we were doing. But Paul Older found this cutoff of an anaerobic threshold above 11 did well, below 11 didn't. And we thought, that's what we need to know. What we found was it wasn't 11, it was 42, the answer to Douglas Adams' answer to everything, the universe and everything. Actually, by the time we got to that, we'd both done some reading about epidemiology, and we started looking at how can you do individual risk predictions. Now, 20 years ago, if you went to a meeting like this, the great and good would tell you you can't do it. You cannot use epidemiological data to apply it to individuals. That's not true. You can do it, you just might get it wrong. The reason we had confidence to go against the great and the good is we'd come across people called actuaries. Now, actuaries are cleverer than doctors, and they make money by predicting how long you're going to live. So if someone can make money out of it, you can do it. What we found, though, that we could get to the giving individual patients risk predictions about survival and complications, but it still didn't tell you what to do. And that's where we started to find, without us realizing it, we were doing shared decision-making consultations. So what should we do next? Centre for Perioperative Care. I think we need to start developing shared decision-making with patients, with physicians, GPs, surgeons, and I think we need to develop more videos, more teaching materials. I think a bit that we need to develop is providing people with information, clinicians and patients with information on what determines outcome. Because I think there is a knowledge gap that you've got to get over before you have the confidence to do the consultation with patients. I think Osler got this right. There is science in medicine. but there's also an art of probability. So a science of uncertainty and an art of probability. And I think the art of probability is developing your skills and learning from patients to do consultations. Finally, that's a map or a photograph or a schematic of King's Cross. Now, I lived about 10 minutes away from here for 4 years as a medical student. And King's Cross is hugely different today than it was 30 odd years ago. I think this is the future. I think we need to study decision making by patients and patient-reported outcomes. And I'll try and explain what I mean. At the moment, I think we do procedures or investigations based on medical science. Now, that's not saying that is wrong, but it doesn't involve how patients make decisions. It involves how doctors make decisions. And then I think the outcome we need to be looking for is patient-reported outcomes, not doctor-reported outcomes. Thank you very much.